Jennifer Kennedy, the lead for quality at CHAP, and welcome to this month's CHAPcast. I have the pleasure to speak with Jacob Martinez today, and he's doing some really innovative and exciting things in his area in New Mexico. Hi, Jacob, how are you doing?
Hey Jennifer, I'm doing good. How are you?
Great. So can you tell our listeners out in podcast land a little bit about yourself and your program?
Sure, this is my first time to podcast land, so bear with me.
You're doing
Um,
great.
so, a little bit about myself. I've been in healthcare business development for 7 years now. I started in SNFs and then came over into home health. Um, I'm originally from the western part of North Carolina, a very rural area as well. So, rural healthcare seems to be where I find the most, how do I want to say it? Not interest, but stake, because in some ways, having lived in a rural community, um, I know how it works and I know how hard it is in order to have access to healthcare.
Right.
And of course, like we were saying before the show started, I did a stint in the DC metro area as well, where there's lots of resources. And I left the DC metro area and went to Mexico for a couple of months on sabbatical and came to New Mexico. It's a long story that we won't get into here. Um, but I work for Mountain Home Healthcare, which is a nonprofit home health care agency that provides home health, hospice, private duty nursing, private duty caregiving services, as well as now palliative care. We just launched the palliative care division in October during the pandemic, and after about a year of planning in the middle of the pandemic as well. So we're really excited to talk about that and to talk about too the challenges of being in Taos, New Mexico is really interesting. So New Mexico, geographically speaking, in square miles, 3 North Carolinas can fit in the state of New
Is that right?
Mexico. Yeah. Uh,
Oh,
North Carolina has 11 million people living there. We have a little over 2 million people living here. So the entire state almost is of a rural nature. And so we have a lot of challenges for folks accessing healthcare. Um, if I were to be in a car accident, I would get shipped about 2.5 hours away to
wow.
receive
That is
care
rural.
right now. And then of course the demographic, poverty, and the age demographic. The median age is quite high in the state of New Mexico because lots of the younger generation move outside of the state to
Right,
pursue
right.
opportunities or school, et cetera, et cetera, et cetera. So that's just a little
So
brief overview.
no, that's great. And I'm really excited to hear about your innovation. But before we go into that, I just wanted to let our listeners know that, um, Jacob, you're our first provider in our innovation series that we have started just recently, where we asked some providers just to say, hey, what have you done that's been
Hmm.
really innovative in your area that has worked and has been sustainable? And I've talked to really several really interesting people about what they've done, and I'm really happy that you're here with me today to talk about your innovation. So tell us about your innovation, Jacob.
Yeah, I'm really excited that we're the first one to come on the show too, because it often feels like by where we are and being a small nonprofit, we're not a large corporation. We feel looked over a lot. So it's nice to know that we're doing something that's worth talking about. Um, in in New Mexico, in northern New Mexico specifically, anecdotally, there's no data to support this. We do know that the Hispanic and Latino population elect hospice less than the white population does, or the what we call Anglos here. And we know that the indigenous population elects it even less than the Hispanic or Latino populations. And the white population, Caucasian population, Anglo population is the minority here. And so,
Mm-hmm.
by way of where we are culturally, what works in DC does not work here, and the
Oh,
way
right,
we
yeah.
the way we educate is different here because the needs are different. There are different cultural needs that are happening here. And so one of the things that we noticed anecdotally, just by comparing ourselves to counties with similar median ages, similar populations, we noticed that our hospice election between us and the other hospice agency that's here in town, that our census, our average census, ran much lower than those other counties that we're using to compare with. And so, you know, we really started to think about why. Why is that? You know, we have the cultural competency training. We're talking to families. We know this makes a huge difference. We also know that our population here, just because of the things that I mentioned earlier, tends to
Mm-hmm.
be a sicker population because they are not they don't have access to as many options in healthcare. And so
Right, right.
we started asking ourselves, because when we would have someone elect hospice that had been resistant, or um, families that didn't, maybe a daughter didn't want us in there, but brother did, and brother was POA or something like that, and we would see the light kind of come on, right, with daughter or with family member, and they would
Right,
go, oh
right.
my God, I can't believe, you know, this patient has been appropriate for the past 5 months, 5.5 months. Why weren't we getting that election period earlier than we were getting it like 2 weeks before they passed, or sometimes even within 72 hours, you know, because
Yeah,
they
and you have
presented.
short stay patients, right, which is a whole different slew of problems,
Oh,
right?
it's especially for a small nonprofit that works, you know, it's harder and harder for small, just one area nonprofits. We don't have branch offices. We can't spread out our admin overhead over several counties or district offices. So we incur a lot of the costs, which makes it harder to operate. So when you have these 72-hour, I mean, thank God we were there to help in this crisis. But
Right.
when you're looking at the finances of a 72-hour hospice patient, it's a red hospice patient. It's not in the
Sure.
black. And so if that's all you're doing, you don't have a hospice for very long.
Right.
And so we said, how do we educate people better? And one of the things that we did when we were doing some studies just with our referral sources, our PCPs, our hospitalists, um, SNFs, acute care rehabs, was the word hospice freaks people out. You know, and that's
Yeah.
something we do have a large immigrant population here, and that's something we had already been talking about because, especially from Latin America, the word auspicio means an institution, a facility that you're taken away from your family. So when you try
Mm-hmm.
to translate, if somebody's speaking Spanish to a patient and they say, you know, your physician wants hospice and they use the word auspicio, well, that has this really um, sterile institution feeling to people that have migrated here from Latin America. So we've changed how we use the term in Spanish. So we were already thinking about some of this, and and so they said, well, hospice scares people, and so we also said we know we're losing a lot of people that aren't ever going to elect hospice, but
Right.
we know that they're going to the ER all the time. We know that they're staying in the hospital more frequently than they need to, and they're also going out without emotional or mental support through a terminal slash life limiting diagnosis, you know?
Right.
And so we said, how do we take care of our population better? How do we take care of our community better? But our population doesn't respond well to hospice. And the other thing to do in that situation is palliative, because we can still help. They can still be seeking curative treatment. We kind of, by nature of being a nonprofit, we were able to procure grants, some large philanthropic donations for the program. And so we launched. We found a nurse practitioner that was really, had lots of experience in hospice. And so we launched the program with an NP and an LCSW, along with intermittent LPN services or chaplain services should they need those. And so our palliative program was kind of born at that point.
I love that you said I didn't have any data to support, but you did though.
We
you
did.
did almost like a mini environmental scan to really look at where the gaps of care were in your particular community, and figured out that hospice was a scary area of healthcare for your specific population, and you solved the problem here, and developed a community-based palliative care program, which I love that, because that's truly what community health is
Right.
really looking to see where the gaps are and being the provider that fills that gap. Well, Jacob, I love what you're doing, but I imagine this is so innovative for your area, but I imagine the implementation of a community-based palliative care program had some challenges. Could you talk to me a little bit about what those were?
Yeah, we've had a lot of challenges. I think the biggest barrier has been, as a small nonprofit, in order to get into some of these more high-level trainings, it cost a great deal of money to send a team somewhere else. So not only do we have to pay for the admission price to go somewhere,
Right.
but I've got to pay for that nurse's time or that nurse practitioner's time. I've got to pay for the LCSW. I've got to pay their way to get there, and it just wasn't feasible for us. So luckily we have an outpatient clinic here, not here in Taos, but in Santa Fe, which is about an hour and a half south of us. And so they were wonderful. They got on different conference calls with us. We also, the PHS system, the Presbyterian Health System, also has an outpatient, and they've actually started just a little south of us now a home-based palliative care program as well.
Oh, great!
Yeah,
That's
so
neat.
we're doing a little bit of a domino effect here. The other thing is that for a home health hospice agency to break into a palliative care program, it's the billing structure. You're almost operating as if you're a primary care clinic or a primary care
Right.
physician. So there's different PTANs that are involved that we weren't necessarily aware of. We started before we even knew that we needed a PTAN. We're like going back and like fixing some of the billing stuff that we did. And the billing is totally different in the way that like home health and hospice bill out for reimbursement compared to how a palliative visit goes, because that looks like a physician billing for an office visit. So there's been, and there is, I do want to say that we're almost a year, we've got September, October, and we're almost a year into this program. There was and is a learning curve. We're still fixing stuff,
Oh, I imagine so. Yeah.
Yeah, it's been, just today I was in a meeting with billing, and, she was like, what's going on with this? And I was like, I have absolutely no clue. I'm going to have to figure it out. This was my baby, and so they gave it to me. They said, okay, you want it, you got it, manage it, it's yours. But the other thing that's challenging for us is educating our referral sources, because our referral sources tend to want to send us patients that they don't know what to do with anymore, that aren't really appropriate for the barometers that Mountain Home Health has set for its palliative program. And,
Right.
That looks different for every palliative program, because there's, the other challenge is we brought in a nurse practitioner that had been in primary care and family practice for years. And because of our rural setting, I think it's been they're the only clinician provider. I'm not talking about nurses or PTs, but physician providers in our organization. And I think we were going to hire another one when we find somebody that kind of fits the bill for us, because I think them not having that collaboration with another practitioner has also been challenging for them, feeling like they're working in on an island, so to speak.
Right.
And that's something
Right.
that we didn't expect.
So I'm going to shift gears a little bit with us. I'm really impressed of what you've done, and I wanted to know how your program has impacted your quality, your quality bottom line, if you will, of your organization.
Well, one metric that we see that isn't necessarily our metric, it's more of the hospital's metric, or that primary. We have an ACO here. So these primary care physicians really watch this return to hospital, because they know, every time it goes out, that reimbursement is going to get less and less. One thing we've seen is patients stabilize. We'll get the referral from the hospital or from the PCP. They're in the ER every month or every month and a half, and then they get on palliative, and now we may have got that down to like, okay, they're going to the ER. Now we only have like, gosh, how many months of data? 10 months of data. So now they're going every 4 months, And if we had a 24/7 on-call provider, could we, we don't have that yet. Could we affect that metric in a much larger way? Could we get that 4 months to 6 months? And then for folks that kind of come on to our home health division, because they can be doing home health, and we get that sometimes they'll be on home health simultaneous to their palliative admission, because they just came out of the hospital and they need both services. And so we've seen our top 5 DRGs that Medicare watches. We saw that. Now, we already had a great one. We have an incredible, and I will talk your ears off about how good we are. We have an incredible clinical product. So we were at about 7% return to hospital for those top 5 diagnoses. And we're down to 5% at this point. Now,
Oh, that's great.
is that correlated to palliative? I couldn't tell you off of 10 months of data and without digging further into that. But that's the only thing we've done different in the last 10 months is change and we know we're getting sicker patients too, because of the offset from pushing care off from the pandemic.
There's so many exciting ways that you're going to be able, after a year's worth of data, to be able to slice and dice it and see what impact it might have on your other lines of business, hospice, home health, etc. So this is very, very exciting. And Jacob, I wanted to thank you for showcasing your innovation with CHAP today. And, I feel like you did it in such a thoughtful way to fill that gap in your community. And I want to thank you for doing that. Do you have any last words of wisdom for us?
Our census has grown on hospice, and so is our length of stay. We're not seeing as many of those 72-hour turnaround. And I think that's really important for hospice organizations that are struggling with those, that may be considering a palliative care program, to maybe offset some of that. We're seeing our hospice division has stabilized a great deal since enacting and launching the palliative program. I don't have any words of wisdom. I'm just really grateful for the opportunity to talk about palliative care, more importantly about Mountain Home Health Care, and to be speaking to you guys from New Mexico, which is a beautiful, beautiful state with the most amazing people, and I'm just so lucky that I get to part in taking care of them. So I appreciate your time.
Thanks so much, Jacob. We appreciate you coming on the Chapcast. And thanks to all of you for taking time out of your day to plug into our podcast. And hopefully you're taking away something from this really innovative and rich conversation we've had with Jacob Martinez today. So thanks again to you all, and stay safe and well.